All right, so welcome everyone. Today's talk is Understanding and Breaking the Stigma Surrounding Early Psychosis, and this is targeted towards family members and community members. Although if providers are here, you're welcome, and we hope that you also can benefit from this discussion. The STEP Learning Collaborative is a statewide initiative. MindMap is our statewide early detection campaign, which I'll talk about with the support of the state Department of Mental Health and Addiction Services, as well as the Department of Children and Families. We're able to bring these outreach talks to you all. So today we hope to cover a variety of things. Largely, we want to increase awareness and understanding of early psychosis, help folks learn to recognize the early warning signs, understand the importance of connecting to treatment, introducing some basic strategies about asking about symptoms of psychosis, and then in future talks, we can go into more depth about specific communication strategies for different scenarios. And then lastly, we'll hope to dispel some common myths about psychosis. So what is psychosis? When I talk about psychosis, that in itself is not a diagnosis, rather it's an umbrella term. And so psychosis is a medical syndrome that can be diagnosed based on a cluster of changes in thinking, feeling, and behavior. So during an episode of psychosis, individuals really struggle to differentiate what's real from what is not real. And they might come to believe false explanations for their experiences. So although I'll talk about a bunch of different types of symptoms that can be considered related to psychosis, the main part of it is that struggling to tell what's real from what's not real, whether that be noises construed as voices or thoughts construed as delusional beliefs or paranoid thoughts. The crux of it is this issue with reality testing. And so psychosis is more common than you might think. Impacts approximately 100,000 youth and young adults every year. We expect that about 1,500 young people in Connecticut will experience psychosis every year. And so about 3 out of every 100 people. So that's the experience of psychosis, which can happen in a lot of different forms, which I'll talk about. More specifically, the diagnosis of schizophrenia or schizophrenia spectrum disorders is a little bit less common, with only 1 in 100 individuals going on to develop a schizophrenia spectrum disorder out of those 3 in 100 who have experiences of psychosis. Psychosis doesn't, discriminate. It can impact any race, gender, socioeconomic status, religion. And so what is a first episode of psychosis? It's kind of what it sounds like. It's the first time that someone experiences symptoms of psychosis or has a psychotic episode. And so particularly during this time, these experiences can be highly disturbing and unfamiliar, leaving the individual who's experiencing them, they might feel very confused or distressed. And also the family members that are around them might be very confused, bewildered at what is going on, especially if one isn't familiar or hasn't seen this in other family members or other folks before. At the STEP Clinic and within the STEP Learning Collaborative, we focus on the first 3 years since the onset of experiences of psychosis. So we consider that first 3 years to be first episode psychosis. So even if someone's had a couple different episodes within that time frame, that's what we're talking about as first episode or early psychosis. And so what's important to recognize when working with and trying to understand individuals experiencing psychosis is that it's a first episode of something. So although we are aiming in our specialty clinic and with the STEP Learning Collaborative to identify young people who will go on to develop schizophrenia, so we're looking for first episode schizophrenia, it's expected that there's some diagnostic ambiguity or uncertainty at this early age. And so that's an expected part of working with this population. There's not a specific blood test that can tell us, oh, this person has schizophrenia versus bipolar disorder versus major depression with psychotic features, right? So we have to kind of use clinical assessment and time and judgment and expertise and other ways to rule things out in order to make these diagnoses. So just to know that sometimes diagnoses might change, but overall kind of psychosis, that's what we're looking to treat. So what causes psychosis? It can have several different causes, and careful assessment is required to distinguish between episodes that are caused by different etiologies. So we want to make sure that we're considering psychosis that might be coming from a medical illness, such as an infection, epilepsy, Parkinson's, versus psychosis that's only attributable to substance use, so cocaine, stimulants, cannabis. So although there are these other causes that I just talked about of psychosis, The most likely cause is the emergence of a schizophrenia spectrum disorder or other mental illness like bipolar disorder or major depression with psychotic features. It is important for a treating provider, like I said, to rule out these medical or acute substance causes, but a lot of the times it is going to be attributable to an emerging mental illness. Psychosis versus schizophrenia. This can kind of be confusing, right? Sometimes I say these words interchangeably. Again, psychosis, think of that as the umbrella term that can consider kind of this collection of unusual experiences or symptoms that I'll talk about, right? So it could be hearing voices, having unusual ideas, changes, disorganization of behavior or speech. And once a trained medical professional has, as we mentioned, eliminated other causes of psychosis, like those medical causes or a different mental health condition, most likely we're going to be left with a schizophrenia spectrum disorder. Contrary to many myths, these illnesses are treatable, and the earlier the better. Treatment should be individualized, and it can include a combination of things, working one-on-one or in a group with a therapist. Medication is very effective as the first line treatment for schizophrenia, and but also working to help with other important areas of a young person's life, such as supporting their work or educational goals, and also providing support and education to their family and friends. So what are some common signs and symptoms? Perhaps the most recognizable set of symptoms are what we call positive symptoms of psychosis. When I say positive, I don't necessarily mean a good thing here, but I mean positive in addition to or a distortion from an individual's typical functioning, perception, or behavior. So positive symptoms of psychosis would include things like hallucinatory experiences or perceptual changes, so hearing voices, seeing things that aren't there, even tactile, so feeling things, or olfactory, smelling things, or even tasting things that aren't really there or aren't really occurring. Positive symptoms of psychosis also include things such as delusional beliefs, and these can really range in their content. So it can be something that could be very realistic, such as, I'm feeling convinced that my partner is cheating on me or something like that, that could plausibly happen, to a belief that's very bizarre, such as maybe an alien implanted a chip in my brain or swapped out my parent with a clone, things like that. People's experiences really vary. Other positive symptoms of psychosis could include disorganized communication. It's important to recognize that all of these experiences can occur on a spectrum, which I'll talk about in more depth later on. But disorganized communication can range from just being a bit tangential or circumstantial, having a hard time getting to the point in a conversation, to something that like being completely incomprehensible when you're speaking, almost as if it's a different language and you're not making sense to anyone. And another important facet of these experiences is that often they're accompanied by what we call limited insight. And so that means that the individual who's experiencing them, it feels incredibly real to them. Just as how you feel convinced of what my name is, the experience feels just as true to the individual. And so it would be hard to kind of convince them otherwise. And this can be particularly challenging for family members to kind of understand and work with, and even providers. But there are ways through various treatment approaches to kind of help support individuals in increasing their insight. Another set of symptoms. So we had the positive symptoms, now we've got negative symptoms. And again, not necessarily meaning bad, but negative meaning a reduction or a loss from an individual's typical functioning or perception. So these might look a lot like depression at times. So negative symptoms might look like decreased motivation, less energy, less speech output. We might behaviorally notice a social withdrawal in your young person, a flatness in their affect or their emotional expression on their face. You might see a decline in their overall functioning, paying less attention to their hygiene. And the things with negative symptoms is that even if someone is feeling like less motivated to go do, say, a family activity, we know that individuals who are experiencing schizophrenia, although they might struggle to experience that anticipatory pleasure or enjoyment, to know that like, hey, if I go do this family activity, it might be fun and I'll have a good time. Once they're actually doing the activity, we know that folks can absolutely experience pleasure and enjoyment. So that's really where, families can come in and really encourage their young people to kind of try to continue to maintain engagement in life, whether that's encouraging them to kind of come out of their bedroom and eat dinner with the family or go for a family hike or outing, all those ways in which you can kind of, even if the young person is struggling to initiate, sometimes your support and guidance can really help them still engage in important behaviors that they might find enjoyable. Other common symptoms would be cognitive symptoms. So we know that for some people, they experience a decline in their executive functioning. So that might impact things such as planning and attention, working memory, learning. So it might be harder to think abstractly. So again, not everyone is going to experience all of these symptoms or all of these domains, but we do know that folks experiencing schizophrenia can be impacted in these different areas. And lastly, we know that folks' mood can be impacted, whether it's fluctuations, anxiety, depression. And as I'll talk about a little bit later, there's an increased risk for suicidal ideation or suicide risk, particularly within the first 5 years of onset of symptoms. Although no two individuals are the same, I'll do my best here to kind of talk about a typical course of schizophrenia. As you can see here, we've got age kind of down on the bottom on the x-axis, and on the y-axis, we've got functioning. And so for most individuals who go on to develop schizophrenia, their early development was very typical or normal. So that's where you see this green box here, or the pre-morbid period, where most folks will have no or few symptoms kind of from birth until adolescence. They're kind of chugging along, developing typically. And then in adolescence, something usually starts to change. And this is what we end up calling the prodromal period, where you might start to notice some low level or attenuated type symptoms. So maybe an individual starts having a little bit harder time in school, their grades drop a little bit, and maybe they're not hearing fully formed voices, but maybe they start to hear whispers, occasionally feel like someone might be calling their name and it's catching their attention. Maybe a young person might start to feel a little bit more suspicious of their friends, but not really sure why. So they pull back a little bit from their social group. So these again are low level symptoms that have not reached the threshold of full psychosis. And just because someone is experiencing some of these attenuated or clinical high risk or prodromal symptoms, we call them a bunch of different things, it doesn't guarantee that they will go on to develop full psychosis. But for those that do, these symptoms usually occur about 1 to 3 years before the onset of a full psychotic episode. And so then typically in kind of later adolescence, maybe between 16 and 25, we see a first episode of psychosis where those symptoms go from kind of a lower level, oh, there was just whispers that I was able to ignore or shake off, or just random thoughts where I felt a little suspicious, but I wasn't very paranoid, where it changes to being much more intense and interfering, and the person becomes fully convinced of these experiences. So instead of whispers, it's fully formed voices that might be telling them to do things or that are very preoccupying. Instead of just a low-level suspiciousness, it becomes full-fledged paranoia, where someone might be convinced that, someone in their school is out to get them and plotting against them, or they're being tracked in some way. I'm just kind of coming up with examples. I don't mean to stereotype, but these are some common examples that we encounter when we talk with folks experiencing these symptoms every day. This bit would be where the first episode would happen. And unfortunately, this often results in a psychiatric hospitalization. And then without treatment, if someone's experiencing schizophrenia, most likely they're going to go on to have a bit of a decline in functioning and have recurrent episodes over time. However, the earlier that we're able to intervene, we can prevent future episodes and loss of functioning. And folks can absolutely go on to live normal, whatever that may mean, fulfilling, meaningful lives, have relationships, be doctors or lawyers, be engaged members of their community, have insight into their experiences. So just because someone gets this diagnosis or has this experience does not mean they're doomed in any way. We want people to know that recovery in psychosis is the expectation, not the exception, especially when early treatment is accessed. So I just talked about this a little bit, but why is treating psychosis important? So of course, we know that the individuals and some of the family members here that are impacted by it are having emotional, physical, financial impacts. If left untreated, as I mentioned, Psychosis can often lead to frequent hospitalizations, and as we know that this occurs during that kind of late adolescence, young adulthood, it can really derail functioning at such a crucial juncture in one's life, right when they're about to launch off to college or their first relationships or jobs. Trying to treat it and prevent folks from kind of getting off track, whatever that might mean for them, is really important to promote long-term recovery and functioning. As I mentioned, particularly within the first 5 years or the critical period of psychosis, there is an increased risk of suicide for young adults and adolescents experiencing this condition. 1 in 100 people experiencing first episode psychosis will die by suicide, and as many as 10% will attempt suicide within the first 5 years. There's also long-term kind of cardiovascular and other physical health risks that folks might experience. However, with a clinic that's, monitoring that and trying to address those issues early, we can try to limit the impacts of those risks. We already talked about the initial risk, but other risks factors, as we're working a bit to be honest, but also destigmatize, what we see sensationalized in the media representations of schizophrenia. So the majority of people with schizophrenia are not violent. And just like I said, that risk for suicide is highest in folks that are not in treatment and are using substances, and the same for the risk of violence. So folks that are experiencing schizophrenia are actually 14 times more likely to be victims of a violent crime than be arrested for one. So yes, there is a risk of increased violence of someone kind of acting against someone else with this diagnosis, but really it's out of proportion. And if folks are in treatment, that risk is reduced. And as we mentioned here, violence is often more closely linked with substance misuse than with mental illness. And so there's a little bit more about some of those risks of neglect and victimization. And I'll make sure these slides are available for folks. So what should I look for? So this is taking a step back a little bit more like kind of before the onset of full psychosis, when we're thinking about maybe that earlier adolescence, mid-adolescence, prodromal time period. I won't go through all of these, but they'll be available for reference. These are common signs of young people at risk for psychosis. So some of them are general, right? Some of them are looking like some general anxiety and other mood-related symptoms, changes in motivation. One thing I do want to point out that should raise a red flag for both parents, but also providers, is if you feel like your young person has like a late onset ADHD, that should be a red flag. It doesn't mean that the ADHD isn't real or maybe could have been missed because a young person was, compensating throughout their early schooling, but really symptoms of ADHD should be present from early childhood. And so when folks are coming to a clinic saying, hey, I've got this new profound difficulty concentrating and paying attention, prodromal psychosis or psychosis should at least be in the differential. It should at least be in the conversation to consider, okay, is there an emerging psychotic disorder going on here? Especially because stimulant use in someone experiencing psychosis might exacerbate their symptoms. So it's really important, again, that providers and family members are aware of this and at least considering psychosis as an alternative when someone presents with these new cognitive changes. So I'm not saying that folks who have longstandingly had difficulty concentrating, but again, new changes, a new sudden decline in functioning would be red flags for you. So a variety of other general symptoms, physical, the ones that are easiest to kind of recognize, as I mentioned, are these attenuated symptoms of psychosis. So here's that, again, that low level things that I already mentioned. So starting to maybe see shadows or flashes out of the corner of your eyes when that wasn't previously happening, and wondering, is that something? Feeling like my name's being called more frequently. I'm sure many of us, even if we haven't experienced psychosis, have had that feeling of, is my phone vibrating in my pocket? I could have sworn it was, right? So again, all of these things occur on a spectrum, but if they start to occur more frequently and start to preoccupy the individual more and start to become distressing, that's when we really want to kind of raise the alarm a little bit and wonder, is something more going on here? The most important thing is your children or the young people that you're working with, it's relative changes for that individual. If things were going swimmingly before and then all of a sudden, like I said, a decline in grades, major social withdrawal, a change in behavior, that's when you want to start to kind of wonder what else is going on, whether it be early psychosis or another emerging mental illness. So what contributes to the development of psychosis? There's not one thing, it's complex, but we believe that there's a combination of some type of genetic or biological vulnerability mixed with life stressors and kind of other risk factors that might increase someone's risk for developing a psychotic illness. And those life stressors and risk factors can also exacerbate symptoms or cause recurrence of symptoms in someone who already is experiencing psychosis. This is a list of a lot of different risk factors that are out there in the literature. I'm not going to go through all of them, but I want to highlight some for folks to be aware of. And again, none of this is to be blaming or things like that, but it's just to kind of educate us of what might contribute to some of these experiences coming about. And no one thing is causative, but sometimes, like I said, it's this combination and interaction of all of these. A family history of a psychotic disorder in a first-degree relative, that can increase your likelihood 6 to 13 times more likely than someone who doesn't have a first-degree relative with a psychotic disorder. Childhood trauma can increase the likelihood of a development of a later psychotic illness. 34% of folks with FEP report experiencing childhood sexual or physical abuse. And I imagine that it's even a potential underrepresentation. And we know that PTSD is 10 times higher in folks with schizophrenia than in the general population. That being said, just because someone experienced some type of childhood trauma does not guarantee that they are going to develop schizophrenia later in life. And it does also not mean, if someone has schizophrenia, it doesn't mean that they had definitely experienced trauma early in their life or at any point. And I also wanted to point out and really highlight substance use, especially cannabis. And for folks that might have been able to join our talk earlier in the month that was focused on psychosis and cannabis, we know that adolescent cannabis exposure can increase someone's risk 2 to 4 times, increase the risk of developing a schizophrenia spectrum disorder than someone who does not have cannabis exposure in adolescence during that kind of critical time when the brain is still actively developing and pruning. And so what we should know about risk in cannabis is that it seems obvious, but the greater frequency, the greater duration, the earlier first use, so someone starting at 12 instead of 20, and of course the higher potency of the cannabis, so the higher THC level, all of those things will increase the risk of experiencing psychosis. And then there's also an increased risk for folks with a childhood migration history, particularly for those who are a minority coming to a different culture and different country. I've already given you some examples and some of the different slides, but I really want to bring some of these experiences to life. So I'll share a few kind of amalgamated quotes about what these experiences of psychosis actually look like. And so most of this is focused again on those positive symptoms. What I'm going to share with you are responses that occur on a spectrum. So responses that we're going to start with ones that are kind of a bit more attenuated or prodromal, so not full psychotic symptoms, to ones that are a bit more intense and the individual doesn't seem to have insight into what they're saying. So someone, might say, lately I've had a hard time telling what was in my dream and what was real, right? So that might be kind of a low level symptom that someone might share coming into like a prodromal clinic. Doesn't guarantee that they're at risk for psychosis, but it might mean something if you contextualize it with other things that are going on in their life. So in terms of disorganized communication, someone might say, everything has started to sound too loud or too close, and I can hear everything at once. So we know that for individuals experiencing psychosis or developing an emerging psychotic disorder, that there's a change in what we call kind of sensory gating. And so typically our brains, if they're functioning the way that they're supposed to, they're able to filter out information that's not important and help us pay attention to only the salient or important information in an environment. Someone calling my name, Laura, emergency siren, something like that. That's really supposed to be salient and important. We know that something starts to change in this sensory gating ability when someone starts to develop psychosis, and basically the floodgates open for some folks and all the information might come pouring in. Everything feels salient or important. And for some folks, that can just be so overwhelming. They might want to put headphones on. They might want to retreat to their room. This is important to differentiate because some people might have this experience from early childhood. Some folks that maybe are on the autism spectrum or have other types of sensory difficulties or vulnerabilities, may have always experienced, sensory sensitivity and easily overwhelmed. For new psychosis, again, we're really looking for that change. For someone who wasn't experiencing this, but then all of a sudden are becoming easily overwhelmed and having a hard time telling what's important. Noticing patterns or random occurrences. So this type of response might be, I keep seeing blue cars and I wonder if that's a sign I should pay attention to. I think about it a lot, right? So that's the brain kind of saying, hey, here's something that's salient or important. All these blue cars, you should maybe look out. That might mean they're out to get you, or there's a sign that you should be doing something. A provider would kind of ask more questions about how the individual is making sense of that and what they think about it. Every time I hear my classmates laughing in the hall, I'm pretty certain it's about me. This might be a common experience for a young adolescent who's feeling self-conscious or a little bit socially anxious. So it's important to differentiate, is this just social anxiety? Or if you ask a little bit further, hey, why do you think they're laughing about you? And it's usually because, I think, they're plotting against me or they have malintentions, as opposed to just, they're judging me because I don't wear the coolest clothes or I don't have friends, right? So to differentiate between anxiety and potential psychosis, anxiety would be more about social evaluation, judgment, whereas more of a suspiciousness, paranoid interpretation might be someone's kind of out to get me, plotting against me with malintent, some persecutory nature of the thought. Sometimes I feel like my thoughts are being broadcast out loud for everyone to hear. So that's why I don't leave the house. So here, right, someone's got a kind of an unusual thought. They're worried that others can hear their thoughts, and you can see that it's majorly impacting their behavior. They're not able to leave the home. So maybe they stop going to their job or school or engaging in important relationships. Eminem is sending me coded messages through his songs. And you know what, Dr. Sykes, it's because I'm famous too. So this is another example of someone feeling like, a special message or what we call an idea of reference that folks might notice in billboards, TV, radio, newspapers. And there's a little bit of grandiosity tied to that too, into the interpretation. Like, I'm getting special messages because I'm actually famous. But then maybe you ask the person, do you actually produce any music? Or do you know Eminem? And like, oh, no. So you could ask, additional questions to try to understand how someone's coming to that conclusion. Another example might be, I can actually control other people's emotions with my thoughts. It's a special gift. Some folks might feel like they're being tracked, and you ask a little bit more, and maybe it's because there's an underlying belief that there's been a chip planted in their head. And then, of course, the kind of hallucinatory experiences. Someone might say, I'm hearing voices and they tell me that I'm no good, and they actually tell me that I should hurt myself. So that would be an example of a command auditory hallucination. Not all hallucinations are command in nature. Some of them folks really report as being positive, not valenced at all negative. These are just random examples that I wanted to kind of share with you to bring to life a little bit some of the different experiences that folks might encounter. This is a pretty clinical slide, but I wanted to really drive home for folks that symptoms of psychosis occur on a continuum. This is an example question from the structured interview for psychosis risk syndromes that we use in the STEP Learning Collaborative to assess both for the risk and presence of psychosis. And so here's an example question. Have you ever found yourself feeling suspicious or mistrustful of other people? So an answer that's in the normal or typical limits might be, I don't completely trust my new roommate, but my mom told me not to trust people right away anyways. So there it's just like, okay, that, person's responding based on their family upbringing, and it's not really interfering in any way. A response that might be in the clinical high risk or prodromal range might be, I think my roommate might be poisoning my food in the fridge. Sometimes I throw it out just in case, but I'm probably just being paranoid. So there you've got a pretty compelling thought that's impacting the individual, so much so that they're even acting on it. Sometimes they're actually throwing out their food, but they spontaneously have that insight. They're like, that might just be me being paranoid. So that would still be considered in the kind of prodromal or clinical high risk range. Or for someone who is already experiencing psychosis, that would be a more attenuated symptom. And then when we have more full or frank psychosis, a response might look like this. Dr. Sykes, I am certain that my roommate is out to get me and is poisoning my food. Sometimes I don't eat for days. So you can see with this response that the person is absolutely convinced that this is happening, that they're being poisoned, so much so that it is significantly impacting their behavior and their physical well-being. So much to the point of maybe if you asked further, you might see that they're malnourished and might actually need to maybe go to the hospital because they might be considered gravely disabled because they might be so impacted by these paranoid thoughts that they're not able to safely take care of themselves. You can see the difference here, full kind of conviction, significant impact on their behavior, and it might even be endangering their well-being. This is a scale that we use, again, to kind of assess and understand things, but I share it with you all just so you can kind of see the different ranges that folks might fall in. And it's important to recognize that just because someone is experiencing a symptom of psychosis where they're fully convinced, it does not mean they need to go to the hospital. It does not necessarily mean they're dangerous in any way. People walk around kind of every day with symptoms of psychosis, but if it's impacting them, it generally means that we'd want to get them connected to treatment as soon as we can. So I'm not going to go through all of these, but again, these are kind of references and helpful for providers or families to just maybe even know how to ask about symptoms of psychosis. Some strategies, you want to kind of ask soft questions and be patient, be curious, try not to overreact. Again, this is generally the role of a clinician, but I want to share it with family members or community members because we know that you all are the ones who are maybe the first line kind of interacting with young people where you might suspect or first detect these experiences. It's also super important to consider cultural explanations. If someone's family has a strong belief in ghosts and spirits and that is meaningful for them and is not distressing and other people in the family or community believe it, we don't want to pathologize that as an experience of psychosis. If it seems like it's going above and beyond what other people in their community believe, or it's a new experience, or it's causing significant distress, then you might want to look into it. It's important to recognize that we don't want to argue or dispute if someone is experiencing a kind of a full delusion. If someone is convinced the FBI is following me, I know it, they've hacked my phone, my laptop, I had to throw all them out. You're probably not going to get very far with kind of saying, that's not true, that's crazy, that's not happening. If the person is fully convinced of that in that moment and experiencing full psychosis, telling them that it's not real is likely not going to be helpful. But what you can always do is validate the underlying feelings. So say like, wow, that must feel really scary or really invasive to not know who you can trust or to feel like your privacy is being infringed upon. We'll go into this a lot more in the next workshop where we really talk about communication strategies, but I just wanted to give you a little bit of taste of what that might look like. We've already kind of mentioned this. I mentioned it throughout that intervening early is important. We know that early intervention within the first episode or shortly after can have good clinical, functional, and cognitive benefits, can reduce the risk of that those who are untreated might experience, so can reduce the risk of social isolation, unemployment, homelessness, and risky behaviors like harm to self or others. I know that we might have varying people in this audience, but if you are here and you're just a community member or you're trying to connect someone to care, you're a coach or other family member, if you see the signs of psychosis, know that we have a centralized referral line in Connecticut now. It's this number, 203-200-0140. That'll connect you to the STEP Learning Collaborative, which will do a screening for psychosis, and if the person's eligible, we'll try to connect them to care near them as quickly as possible. So I'm not going to go through all of these slides. Some of them I'll skim over a little bit, but the pathway to care, right, as we've kind of talked about, remember that psychosis is treatable. The earlier that people get help, the better. So part of our goal with the STEP Learning Collaborative is we've launched this campaign called Mind Map that you might have heard of, which is what we call an early detection campaign. And so with Mind Map, we're trying to educate the public as well as clinicians and other referral sources about what psychosis is so that folks can get young people into care as quickly as possible and kind of notice, hey, that cousin of mine has been kind of staying in the basement the past 6 months and they used to be really active, or they dropped out of school, or, there could be various reasons for that, but to kind of cause folks to kind of question and reach out and try to connect them to care. And we know that certainly a young person has to be willing to connect to care. And that's another barrier that we often face as family members and providers. But we at least want to have the people around them kind of know what's going on and try to help support their efforts to connect. So as we already mentioned, symptoms are usually occurring in late adolescence, young adulthood. So the ages of kind of 16 and 35 are key. Family members are so important. Family and friends know their loved ones better than anyone else. You all are often the first ones to notice when something is off and play a crucial role in identifying and having that knowledge of, hey, has there been a family history of schizophrenia or a family member that's been hospitalized psychiatrically for a long time or was never able to return to work? And again, not that schizophrenia has to mean those things, right? We don't want to stigmatize or perpetuate those myths, but asking yourself those questions if formal diagnoses weren't shared in our families, which certainly was more common in the past, kind of looking back at our family history and recognizing, hey, has this occurred in our family? That could really help inform your young person's kind of treatment and understanding of what's going on for them. And we know that anyone who's interacting with a young person can be helpful to kind of detect early psychosis. So, right, whether that's a coach, a teacher, of course, parents and family, but counselors, law enforcement, all of these folks can play a key role in connecting young people to care. And so that is why Mind Map is really working to educate all of these different stakeholder groups, right? We're going out to schools, we're meeting with police officers in the community, reaching out to youth and family agencies to make sure that people know what psychosis is so that if they see it in a young person, they can try to help connect them to care. And that can be by calling our centralized referral line. And so here's the number that we already talked about. I know that some of the folks in this group might be parents who are already connected to care, but if you're not, please feel free to hang on to this number and share it with anyone where it might be relevant. We know that there are obstacles to getting to care. People generally wait longer than they need to before getting help, even when it's clear that an individual might be experiencing symptoms of psychosis. So we know that there can be stigma associated with it, right? We might be fearful, I don't want my child to experience psychosis, or I see what that looks like in the movies or the media, and we see these stigmatized portrayals. And so it makes folks afraid to seek care or to open up about their symptoms. You might be in denial. There's no way this can be happening. No, they're just depressed, or they're just going through a difficult season. They'll be fine. It's just a phase. And that could be true, but right, we want to get folks connected, and we'd rather kind of check it out and rule things out than let them wait. A lot of times there's confusion. People don't know what these symptoms are or how to make sense of them. And other barriers might be having to wait a long time for an appointment, which is something that we're trying to improve across the state by streamlining referrals for psychosis and trying to reduce wait times at all the different participating agencies across Connecticut. So quickly here, I'm going to go through some myths versus facts. Myth: psychosis is really rare. No one in my life will be impacted by psychosis. Whereas in actuality, as we talked about, it's more common than you might think. 3 in 100 people will experience psychosis in their lifetime. Treatment doesn't work, right? Having schizophrenia is a death sentence and there's no help. That's absolutely false. The facts are treatment is very effective, and the sooner the better. People experiencing psychosis and schizophrenia can absolutely go on to live successful and meaningful lives. And I've seen it both in my personal life as well as my professional life every day. Myth: treatment is scary and painful. We don't want to believe what we see in the movies. Treatment is safe. Treatment typically consists of medications and therapies, and often just involves going into an outpatient appointment once a week into an office and then going home, or even engaging via telehealth. Yes, sometimes treatment involves a psychiatric hospitalization, but it doesn't have to be scary. And so again, you can kind of call our referral line to get connected to outpatient treatment. Another myth: treatment means being in a hospital or psych ward. As I mentioned, especially the earlier that we can connect with folks, the early treatment's able to happen in the office as an outpatient appointment. Our goal is to get every individual experiencing psychosis into care on an outpatient basis before they end up in a crisis situation where they might need to be sent to the hospital. Myth: people with psychosis are violent and dangerous. And so it's important to, even though I hate this language, it's important to differentiate here. Psychosis does not mean psychopath or psychopathy. People with schizophrenia are more likely to be a victim of violence than actually cause harm themselves to others, right? So what is often portrayed in movies and things is not accurate, is not your typical experience, and that unfortunately often further stigmatizes folks and prevents them from seeking the care that they need. Myth. It's not psychosis, it's just their personality, a curse, or laziness. That's not the case. Psychosis is a treatable brain disorder, okay? This is not something that's made up or that's a lack of will. So unfortunately, a lot of times people around individuals experiencing psychosis might unknowingly ignore the symptoms, as we mentioned, think that it's just something that they can change without support. But we know that early treatment is essential and it can be incredibly helpful to support folks. All right, so I'm going to kind of skip through this. Those were the myth versus facts. This is our efforts that we've really expanded with the support of DMIS and DCF over the last year. STEP is right here, but we're just one little node now in this statewide network of care, where our goal is that no matter where someone is experiencing early psychosis in Connecticut, that they can call this number and get connected to care near them in a quick way. So just want folks to know, I know you're here for the family and community training right now, and that some of you have already attended some of our provider series. Even though we have a provider series, it's open to the public, so any family members or community members are welcome to come. It's listed on our website, and it's the first Thursday of the month on Zoom. Although this isn't relevant to family members, but if you're here, if you're a provider or if you're a interested family member who wants to advocate to their provider, STEP offers a free consultation line to providers where anywhere in the state, someone who's working with early psychosis can put a request form in and talk to myself, Josina, Dr. Shrihari, other kind of early psychosis experts, and we answer questions and consult on cases to support the care delivery for these young folks across the state. There are tons of resources on our STEP Learning Collaborative website where you can look at other webinars, slide decks, videos, links that can help support families. So these are just some of the upcoming trainings. And that's all I have for today. If you're interested, click on that, join our mailing list. You'll get all the updates for upcoming trainings, outreach events, different activities and opportunities. Thank you so much.